Hello, my name is Sultana Childress, and I'm an assistant professor of social work at University of Texas, Arlington. So I'd like to start by articulating why we care about domestic violence, interprofessional education, and practice in healthcare settings. As you're all very aware of, intimate partner violence continues to be a devastatingly pervasive problem, with World Health Organization data showing that across their lifetime, 1 in 3 women are affected. So around 736 million globally and over 10 million of Americans every year. The effects range from serious physical and mental health impacts to economic and educational disruption and increased risk of future and intergenerational violence. It is therefore a critical task for professionals seeking to improve public health to effectively intervene to support survivors and reduce violence victimization. The healthcare system has demonstrated itself to be an important entry point for supporting survivors, and it plays a critical role in identifying and intervening in domestic violence cases with the potential to enact primary, secondary, and tertiary prevention strategies based on the unique situations of individuals and families. So the U.S. Preventative Services Task Force in 2019 provided a set of recommendations for providing domestic violence services in healthcare and highlighted the importance of screening women of reproductive age for intimate partner violence in healthcare settings. Responding to these recommendations, what we did then as a team of social work and nursing faculty was to come together over the course of a year to discuss ways of developing experiential, interprofessional learning activities to support emerging professionals at UTA, students in social work and nursing, to effectively assess and intervene with survivors of intimate partner violence in healthcare settings. As a first step of our activity, we conducted a scoping review of the literature that described the state-of-the-art understanding of the interprofessional education for addressing the survivors' needs in healthcare settings. The main takeaway from the review is that there is pretty strong evidence for the effectiveness of screening, brief intervention, and safety planning models in addressing a range of safety barriers and service access among survivors of IPV. This evidence really underscores the importance of education about safety strategies to promote survivors' well-being and to reduce violence, as well as the importance of preparing allied health professionals to confidently intervene in interdisciplinary settings. What we also found out was that despite the critical role that healthcare providers play in frontline provision of services, there is a lack of training in this area, particularly in coursework, clinical and practicum opportunities, and interprofessional gaps around how interdisciplinary healthcare teams can function to best enhance survivor outcomes. So the goal of this project is to expand opportunities to provide evidence-based, standardized educational programs for emerging healthcare professionals to increase IPV screening and improve safety planning intervention through experiential learning. In terms of interprofessional education, we were guided by the core competencies for interprofessional collaborative practice developed by Interprofessional Education Collaborative, or IPEC, that provided the opportunity for students to learn simultaneously about the dynamics of intimate partner violence and appropriate responses and effective teamwork in interprofessional settings. Our team was comprised of several representatives of the nursing school who specialize in experiential learning using standardized patients in smart hospital settings at UTA. And so we designed this program as a simulation activity that engaged students in hands-on experiences and reflection so they can connect theories and knowledge learned in the classroom to real-world situations. And of course, just when we had a wonderful plan of using smart hospital and designing the in-person simulation, COVID-19 hit, and we had to adapt our simulation to a fully online activity to pilot it among the cohort of social work and nurse practitioner students during the spring of 2021. There was a need to implement social distancing measures in response to COVID-19, whereby online technologies have become the necessary platforms for delivering telehealth medicine and communication that is more digitally connected and survivor-centric, and so our online activity had to respond to that need. And finally, our simulation is informed by an understanding of online technology tools that empower survivors of abuse to make informed decisions about their safety and health. Our design incorporated interactive electronic tools, such as My Plan, that consisted of several knowledge and educational sections, including setting priorities, danger assessment tool developed by Jackie Campbell, which is essentially a validated instrument that measures the level of danger an abused woman has of being killed by her intimate partner, and a personalized safety action plan. These tools are based on psychosocial readiness models, which assume that there are 3 internal factors that create positive change and decision-making and help-seeking. Those are perceived support, awareness, and self-efficacy. And so these online tools built into our study aim to create an environment conducive to facilitate those factors. For example, to address awareness, the tool provides information about violence through dispelling myths about healthy relationships. It addresses self-efficacy by engaging collaboratively with the user to create a personalized safety plan. And it increases social support by assisting the survivor with finding resources and services offered in the tailored safety plan. I'm not going to dwell on the details of the simulation because my colleague Carla will demonstrate all the steps and activities of the Canvas course shortly, but I'll give a brief overview of the simulation. The simulation starts and ends with briefing and debriefing. After briefing, a nursing student is then paired with a social work student to create an interprofessional team. They are presented with a set of learning materials about IPV assessment and safety planning prior to the simulation. The nursing team member first receives the patient video narrative and extensive medical chart to review. The nursing student then completes an evidence-based tool, the danger assessment, based on the information from the video and the chart, and completes a subjective, objective assessment and plan, or SOAP note, outlining their assessment of findings. The nursing student then shares this information via a referral to their social work student colleague, who reviews the material and develops a safety plan based on the patient's risks identified. Finally, the 2 students come together to record a video of their conversation, developing an intervention plan for the patient outlining the IPV risks they have identified and potential safety strategies to share with the patient, as well as their approach for further safe engagement with the patient. So this study then aims to understand the impact of simulation on the student learning outcomes, particularly with respect to their knowledge, ability and comfort intervening with IPV survivors within interdisciplinary healthcare, and reports the results from the pilot group of nurse practitioner and social work participants answering the following research questions. What were the experiences and perceptions of students participating in the event? And did participating in an assessment and safety planning IPE event impact students' knowledge about IPV or confidence intervening in an IPV situation in interprofessional practice? In terms of methods, the study involved a mixed methods design, that is, a web-based quantitative pretest in the 2 weeks prior the simulation, and a similar post-test in the 2 weeks following the simulation, and focus groups with students in order to learn about their experiences with the simulation. My colleague, Dr. Rachel Vostrag, is going to present the methods and the results of the survey shortly, so I'll just focus on the results of the qualitative component, which emerged from 3 focus groups that consisted of 15 social work students conducted by Zoom. I'm not going to take time right now with the details of the methodology, but just to mention a few analytic processes. The interviews were audio recorded, transcribed verbatim, and analyzed using NViva 12 qualitative software using ground theory methods. To ensure the trustworthiness of the findings, data analysis was enhanced through analytic triangulation, peer debriefing, and provision of examples of raw data in the presentation of findings. So really the synthesis at which these 3 focus groups arrive results in 4 main themes. They are interprofessional collaboration, communication skills, the influence of prior experience of working with IPV survivors, and future simulations. So the first theme that emerged from these focus groups was the multiple benefits of collaborating with interprofessional teams in order to meet the needs of the domestic violence survivors. What we learned from the student was that team synergy was an essential aspect of the working relationship between social work and nursing partners. Most of the students said that they experienced a high level of professionalism and unexpected benefits resulting from the challenges of coordinating the collaboration. For example, one student shared, "Working with a nurse, she gave me some information. As for the role of the social worker, I found that I will need to do follow-up appointments and do my own assessment, even though the nurse had given me vital information through her assessment. I had to do my own assessment and figure out resources." The second theme that emerged from these focus groups is the importance of communication skills. The students' narratives revealed that effective communication was vital to understanding one another's professional values, terminology, and roles and responsibilities in order to limit any confusion. For example, one student shared, "The language was a little bit different, terminology. In a clinical setting, it gave me a better understanding of how it works and the importance of relationships as well. Just even trying to understand who would communicate with the patient, who would follow up." The third theme that emerged from the focus groups was the influence of prior experience of working with domestic violence clients, resulting either in gaining real-life knowledge of clinical settings or change in perspective. The students who had no prior experience in a clinical setting collaboration said that simulation portrayed the client in a real-life way and provided a snapshot of how things might look in the clinical setting, whereas students who had prior work experience with domestic violence clients emphasized that the simulation triggered a change in their perspective and better understanding of the situation from a nurse's perspective. And finally, the results pointed toward areas where future simulations could be taken. One area of potential collaboration is expanding the range of scenarios in the simulation, particularly around diversity based on gender, IPV dynamics, or presence of a child or an elderly family member. Currently, we're working on a scenario that includes safety planning for a survivor with a child. Another area of IPE training includes increasing cultural competence and interprofessional collaboration skills. And a third area of collaboration could focus on incorporating standardized communication tools and the assessment of impact of these tools on interprofessional communications. So overall, the results demonstrated promise to enhance professional knowledge and confidence in collaborating with interprofessional colleagues to identify and intervene in IPV cases within the healthcare setting. And now, let me turn it over to our MSW student, Kendall Anekwa, who participated in the simulation, to share her perspectives and major takeaways. Thank you.
Hi, my name is Kendall Anekwa, and I participated in the IPE simulation as a social work master's level student in the spring 2021 semester. I really enjoyed the experience, and I learned a lot from participating. I've highlighted in the following presentation what I believe to be some of the strengths of the simulation based on my experience. The first strength of the simulation that I would like to highlight is that the simulation allowed us to apply knowledge in a lifelike experience. During the simulation, we were given a lot of excellent information and resources, such as the power and control wheel, safety planning resources, and interview techniques to use when working with domestic violence survivors. The simulation allowed us to apply this knowledge in a lifelike situation. While evaluating the client's situation and creating the safety plan and the SOAP notes, I was able to see the various aspects of control and how they affect the survivor's life, and to consider how to engage the survivor using the techniques from the materials. So by actually applying these materials, I was better able to understand them and more likely to use them in a real situation. The next strength is the collaboration or the synergy between the nursing and the social work fields. The collaboration made the experience similar to one that I would actually see in a real field if I was to get a domestic violence referral from a medical professional. Meeting with a nursing student gave me a perspective and expertise that I did not have as a social worker, and it helped me in my service planning. I like that the simulation also asked us to consider how to use the nurse in continuing services, because it's emphasized the need for continued coordination to keep the client engaged and safe, and it forced me to think of the creative ways that we can include other professions in our services as a social worker. The next strength was the multiple dimensions that were given in the simulation about the survivor's experience. So, for instance, this survivor indicated in their danger assessment that in addition to the threat of danger from her abuser, she also had suicidal ideation, which is a very real possibility in a real situation. Therefore, all of my referrals and safety planning during the simulation included addressing this risk as well. I had to think about the many ways in which domestic violence can affect a survivor in addition to just the direct violence, and I would apply this knowledge in my future practice. And I also loved that they used real tools like the dangerous assessment and the SOAP template. I'd read about these tools, but it was a different experience to actually apply them to safety planning and referrals, and now I have a better understanding of what these tools are and how to use them in the practice. So here are my takeaways because of my experience in the simulation. So because of this experience, I have increased confidence in serving domestic violence survivors. I have a better understanding of the various factors and dimensions of the domestic violence experience. I have better understanding of the tools commonly used in domestic violence safety planning. And most importantly, I have real knowledge from the simulation that I have already applied in my current profession. So recently, when working with the domestic violence and my current job in the field, I applied some of the new knowledge I had learned. I used interview techniques that were encouraged during the simulation, such as using open-ended sensitive questions and allowing the survivor to narrate the story rather than asking direct questions. I was also more aware of the many dimensions of the domestic violence experience, and I asked her questions about physical and mental health symptoms to better understand the indirect ways that abuse had affected her and what referrals are needed. This is something that I would not have done if I hadn't done the simulation. I also reviewed the power and control wheel with her, and I helped her create a safety plan. I considered many safety factors that I had not considered before I was engaged in the simulation. I felt more confident in serving this client because of this class and because of the simulation. So therefore, I feel like this simulation is a positive thing, and social workers get real life knowledge that they can apply in the field and that can benefit them and benefit their clients.